Hi, and welcome to Module 3, Lecture 2, Community Health Advocacy and Social Movements. Your readings and media for the week were Body and Soul, Chapter 3. You have your discussion for tomorrow, so finishing that chapter up. You have two videos, Path and a nurse practitioner named Linda Goldman telling you about screenings and diagnostic testing, and two articles. Your Week 6 objectives are identifying the difference between screening and diagnostic testing, describing the resources available to help patients find symptoms of chronic preventable health issues, and we'll look at this through the ECD video from Path, so make sure you watch that video. And applying relevant screening tools to recommend appropriate interventions in education. We'll look at that through the Bartloo et al. Article, just to understand how screening programs work and the accuracy, sensitivity, and specificity in a screening tool. And then finally, outline preventive care programs to motivate individuals to improve their health status. And the article sort of touches on that about teleretinal diabetic retinopathy screening. And also we'll explore that more in our next project update, which will be next module, Module 4. And I'll tell you a little bit about it at the end of this lecture, but you'll have all the details in Week 7. So let's start with preventive care programs. According to the CDC, preventive care includes health services like screenings, checkups, patient counseling, that are used to prevent illness, disease, and other health problems, or to detect illness at an early stage. So your primary, your secondary prevention, when the treatment is likely to work best. Getting recommended preventive services and making healthy lifestyle choices are key steps to good health and well-being, and hopefully we never get to tertiary prevention at all if we focus on these. And CDC has a great website. Definitely scroll through this on your own time. There's they talk about tests, screenings for cancer, STDs, regular well woman and well baby visits, interventions like smoking cessation, weight loss, care for pregnancy, vaccinations, and they also break it down by demographic groups like adults. So they have many preventive care kind of programs for adults, and they have it for women, for children, for women who are expecting, about having a healthy pregnancy, breastfeeding, getting tested for HIV, those all kinds of things. So I recommend looking through it on your own time when you have a moment. So let's talk about first early childhood development in Kenya and how this is a beautiful example for how to integrate a preventive care program into an already existing infrastructure of primary care. So what they were doing was addressing early childhood development in the first 3 years of life. And so the outcomes that they were seeing that instigated this project was deaths of children under 5 years old, violence in the society, in the community, lack of children reaching their full both social potential and economic potential in terms of getting jobs, in terms of educational outcomes. And they also saw a sort of culture gap between health workers and families that they wanted to address through this program. So their main approach was training health workers to integrate ECD into primary care visits that were already happening for growth monitoring and screening for developmental milestones for children. And if any of you have children, you know that these visits to the doctor just to check on the development are so important. And so what they were doing was developing these ECD framework, which included things like interactive nurturing play, and training both nurses and physicians on teaching parents about play, the importance of play, um, engaging the production of locally made materials to develop toys if there's a lack of toys shortage in that area, or the toys are too expensive, so making locally made, and teaching the health workers how to teach parents about touch, massaging, talking to babies, and sensory stimulation for kids, and as well as intellectual stimulation for small children. So health facilities were made more family friendly. Um, so they would have play centers for stimulation in the waiting rooms, as you saw in the video, and household level community health workers who were volunteers would go out to families, new parents, and teach, first of all, identify gaps in the knowledge of parents, and then teach them about this ECD concept. So I just thought this was an amazing example in 4 minutes on this really comprehensive intervention for sort of a preventive program and even incorporating screenings as well. So screenings is a huge topic for every disease, for GI screenings, for cancer screenings, for depression screening, for trauma screen. There's all kinds of screenings. And the idea in the big picture is that they should be cost effective, that that any screening program should be able to be performed on a large number of healthy individuals, that is a general population of people, and identify patients or those who need the next step of diagnostic testing. And so the difference between screenings and diagnostic testing is that screenings is the first part, and diagnostic testing is the next step. So it would be a further investigation of disease status after screening test identifies a positive. So examples of diagnostic testing are breast biopsy after a positive result on a mammogram, which is a screening test. A chest x-ray after a positive result on a PPD, which is a skin test to look for the tuberculosis, and MRI, magnetic resonance imaging. You've heard that a lot, I'm sure, in your workplace, and it's used for many different diagnostics. And it also can be used for screening, but generally, when there's an admit to the emergency room and some problem has been identified, the next step is an MRI, an ultrasound, a sort of diagnostic imaging. So screening tests, examples of this, so pre-diagnosis and pre-diagnostic testing. Blood pressure is actually a screening that's used for almost everyone who comes for a medical check. The medical assistants will usually do a blood pressure check, or nurses, before the doctor even comes in to identify risk for hypertension. Cholesterol is a blood test to identify the needs for hyperlipidemia testing. So both of these are pretty common screening tests that happen very often at general checkups with the doctor. Pap smear is, I think the full name is Papa-Nicolau test, to identify women who need further diagnostics for precancerous changes. And mammogram and PPD we spoke about in the previous slide. Mammogram is especially important for women over 50 to test for breast cancer. And PPD is a skin test to determine further diagnostic testing in case of tuberculosis. So the definitions. So the Baratlu article gave you some really clear definitions of these screening vocabulary. So patient is positive for disease, healthy is negative for the disease. True positive is number of cases correctly identified as patient. False positive is number of cases incorrectly identified as patient. True negative is cases correctly identified as healthy. False positive, number of cases incorrectly identified as healthy. And if you think of it in terms of a pregnancy test, maybe one of those home kits that you can buy at Bartell Drugs or Rite Aid, a true positive is the test comes out, with that plus sign for positive, and the person is actually pregnant. False positive is plus sign, the person isn't pregnant. True negative is minus sign, the person is actually not pregnant and the test is negative. False negative is when the test is negative but the person is pregnant. So accuracy in screening, there'll never be 100% accuracy in screening, but accuracy is basically the ability of a test to differentiate the patient and healthy cases correctly. So to estimate the accuracy of a test, you have to calculate the proportion of true positive and true negative in all evaluated cases. So mathematically, accuracy would equal true positive plus true negative over all cases. So that would be true positive plus true negative plus false positive plus negative, false negative. A screening test, so there's two basic parameters of a screening test. There's sensitivity and specificity. Sensitivity is the ability of a test to determine the patient cases correctly. To estimate, you would calculate true positive divided by true positive plus false negative. Specificity is the opposite, so it's ability of a test to determine the healthy cases correctly, which would be true negative over true negative plus false positive. So we have three scenarios in your Baratlu paper. The first one is, imagine we have a sample of 100 cases, 50 healthy and the others are patient. If a test can be positive for all patients and be negative for all the healthy ones, it's 100% accurate. And this is how the schematic kind of looks for that. So taking into account the mentioned statistical characteristics, this test is appropriate for both screening and final verification of a disease. Scenario 2 is that the accuracy of 100 cases that have been tested, the test determined 25 patients and 50 healthy cases correctly. So therefore, the accuracy of the test is equal to 75 divided by 100, 75%. The sensitivity from the 50 patients, the test has only diagnosed 25. So it has 50% sensitivity. Specificity, from the 50 healthy people, the test has correctly pointed out all 50. So it has 100% specificity. And this is how the schematic looks. Negative, positive, these are the patient and healthy. So according to these statistical characteristics, this test is not suitable for screening purposes, but it is suitable for the final confirmation of a disease. In scenario 3, out of 100 cases, 75% accuracy again, but in scenario 3, the sensitivity from the 50 patients is 100% because all the patients have been identified, but specificity is only 50% because from all the 50 healthy cases, the test has correctly pointed out only 25. So when it's high sensitivity and low specificity, this test is suited for screening purposes, but it is not suitable for the final confirmation of the disease, as you can see in this schematic. And we'll see you in part 2.